all the 3 talks are now open for comments and queries.
First to Ashish. Thank you. Ashish, has anybody studied the role of fat in spread of the tumor? I mean, it's very simple. Patient with MFLD, if they have tumors, do they grow slowly as compared to those who don't have MFLD?
I'm not aware of this, because all these studies would require biopsy from the tumor itself. The tumor microenvironment would
MFLD, you know that there's a lot of fat in this
yes.
the liver.
So whether the tumor obviously
the stroma is more important.
Yeah, in those patients who have NAFLD, and so we have seen certain studies which have shown initially that immune checkpoint inhibitors were less effective in those patients who had NASH-related HCC.
No, I'm not talking about the spread of the tumors. Because, you know, conventionally fat retards the growth of tumors. Male breast cancers are more aggressive than female breast cancers.
So I'm not aware of any studies which have expressed.
And to Dr. Bajal, you've shown radiological response. What about the clinical response? Do the patients survive more? That's important for us.
That you have to tell me. My topic was radiological response.
That's the, you know.
That's why we look at progression-free survival and overall survival. So that is what is all studies we look at.
Can I ask one question to Dr. Bajal? So there are, nowadays we use multimodality treatment. So there are tumors which are small, which are big in a single patient. So for one, you will be using maybe TACE or TARE or something. For the smaller ones, the immunotherapy would go on, which will be effective in all. So then how do you assess the response when you have multiple tumors of varying degrees and which have received different treatment? Some have received microwave and all.
So what they've said is that you must use targeted tumors as your index tumor when you're evaluating a specific modality. So when you've done RF, you evaluate only the target. And in fact, they've said that you must not use LIRADs on tumor staging or qualifying tumors if they are beyond your treatment domain. For example, for surgery, for resection, they've said, use LIRADs to talk about tumors at the cut edge of the liver but not distantly away. The other point, your question is very valid, when it starts mixing up combination therapies, and in combination therapies, which is the criteria to be used. So once the first treatment is over and you've moved on to a systemic therapy, then it will be the systemic forms of therapy which will be evaluated as per the criteria for systemic therapy.
Sir, I'll just would want to ask your thoughts on this. All these guidelines which we're talking about is more applicable to actually clinical trials. Now, when we come to individual patients where you have done TACE for one lesion, RFA for another lesion, and 3 new lesions have come up for which you have given a systemic therapy, I think what we need to report is, depending on what modality was used for that particular lesion and what is the response. Your thoughts on this?
Exactly the same. So if you've done RF for one lesion, you stick with evaluating that. But once you brought in a global therapy like systemic therapy, which could impact even residual or recurrent disease on your index treatment, you've got to use the immunotherapy standards. But if you're using multimodality focal treatments, then you continue using either the non-radiation or radiation lexicons based on what you have used.
My question to Akash Shukla sir. Sir, for considering immunotherapy in patients with hepatocellular carcinoma with portal vein tumor thrombosis, if the patient is having high risk varices, is it required that we should, prior to introduction of the regime, we should eradicate these varices, either esophageal or gastric?
So eradication is not necessary, but if they are high risk varices, remember that if they bleed on bevacizumab, then the bleed can be torrential and uncontrollable, and patient may not even get the opportunity to reach the hospital. So therefore, it is imperative that we treat the varices before we. So whenever, usually after band ligation, you can wait for around 2 weeks and then start the therapy if the high risk varices have been sufficiently treated. You downstage them. I think 2 weeks is usually reasonable to wait in most of the patients. There are certain situations where you really find very large varices, gastric varices, esophageal varices, there I think it's a question where you really want to give immunotherapy or not, where you think it is not possible to control the varices. There you may opt for something like lenvatinib actually.
Okay, sir. And my question to Sanjay sir. Sir, for patients with portal vein tumor thrombosis, as per the INAZL classification also, who are considered transplant ineligible, is there any, as per some recent studies, is there any scope that these patients can have novel therapeutic modalities like SBRT or TARE, and they can be considered for eligible for transplant if there is response, particularly for segmental tumoral thrombosis?
No, so you have the data that has come out of our hospital in which we've used this combination of Y90, SBRT, and then downstage them and got them to transplant. So there's a publication there which I would encourage you to read. And I think later in the day today, Dr. Soin is going to speak exactly on this specific topic of transplanting after downstaging HCC with PVTT, which has been our experience, and we have been doing it aggressively.
Okay, thank you.
These patients are often treated by either the hepatologist or the oncologist, and the current trend is to use multimodality, once there is a spread or large tumors. And interpretation, it's getting more complicated. The radiologist will report something, there's a new lesion or, some terminology which is neither the hepatologist nor the oncologist is going to understand. So is your message, the message to the clinicians should be very clear. Is it that all these patients must come to a tumor board where everybody is present and then a final decision is taken, or do you have some simple answer for the hepatologist or the oncologist?
So I think all patients must come to tumor boards. I think this is non-negotiable. There is level 1 evidence, including trials and meta-analysis, that when patients have been managed in tumor boards, the outcomes are better as compared to when individuals have taken the decisions. And you are absolutely right. There is so much explosion of information and data that it is impossible for any one person to keep in touch with everything that is happening. So even if those people are working only on HCC, it is impossible to keep track of all the papers. I had a talk around 2 months ago on the recent advances in HCC, and when I just searched on PubMed, in 1 week there were 1,243 publications on recent advances. So it is impossible to keep track, and that's why I think 5 wise men will be better than 1.
So extending to your question, so one way for response is complete response, partial response, stable disease, and progressive disease. So if that is applied to all these patients, so whatever mode of treatment you have given, so objective response rate, that is much simpler than all these complicated terms which we are not familiar with.
Yes, ma'am.
Dr. Akash, now with the advent of immunotherapy, are we contemplating biopsying these tumors before we start?
So again, excellent question. So far, unfortunately, biopsies and the PD-1, PD-L1 expression on the biopsies have not correlated with the tumor response. And the reason for that is, again, you are not taking the whole tumor. And the expression of these receptors can be differential. There can be more than 1 mutations which are present. And therefore, we probably would be more relying on liquid biopsies if you really look at today's era. But I think we would be probably developing these tools. Unlike other malignancies where you get a large specimen in liver, usually you will get a small specimen when you do a biopsy, because these are not excision biopsies. Most other organs, you get excision biopsy and you get a large tumor, and therefore you can study these expressions better. So this is one of the major limitations in liver biopsies, and therefore even today it is not being recommended, except for now identifying whether it's a cold tumor or a hot tumor, and to assess the microenvironment, I think, which is what Ashish so beautifully highlighted. So yes, it is going to have a role, but we are not there yet. So I think we still need more studies and more data.
Akashji, by biopsying a tumor, aren't you increasing the seedling, the micro seedlings?
So again, come back to the old good debate. So in a large unresectable tumor, is seeding going to impact the overall outcome adversely? I don't think so. But if it is a therapy where you can probably offer a curative therapy, a lesion where you can offer a curative therapy, probably no. So I think it will boil down to those things.
With this, I would like to thank all the three speakers for very, very informative and enlightening talk and very excellent discussion. Thank you all.